And welcome to this CIN webinar, Buying Health for North Carolinians, Addressing Non-Medical Drivers of Health at Scale. I'm looking forward to this conversation. We get a chance to hear from North Carolina's Department of Health and Human Services on their efforts, statewide effort to incorporate whole person care across their work by really building an infrastructure and incentives for addressing social needs like housing, food, transportation, and employment. My name is Marie Hubbard, and I'm the program manager for the California Improvement Network, also known as CIN. CIN is a learning and action network that really strives to advance the quadruple aim by spreading and identifying better ideas for care delivery. CIN is really driven by the innovations and the energy of our partner and member organizations. So really thank you to all of you who are on the call, who really kind of help us shape the work that we do. CIN is a project of the California Healthcare Foundation and managed by Health Force Center at UCSF. You can learn more about our organizations by going to our websites. So I know everybody is tech wizards with Zoom now, so I won't take too much time here, but just want to, for those of you who need a quick refresher, if you have any questions or comments, please use the chat function. You will be on mute for most of our hour here together. We're hoping at the end of our time together in this hour, we'll get a chance to have a little bit of open dialogue, at which point we'll invite you to unmute yourself and ask questions of our speaker, but this webinar is being recorded, so please do remain on mute until then, and use the chat box as your source for getting in touch with the speaker and Christina or I. If you're having any tech issues, please direct message my colleague Christina Travalos and she can help assist you. And now I have the great privilege of introducing our speaker today, Erika Ferguson Walsh, Director of Office of Healthy Opportunities at North Carolina Department of Health and Human Services. So I'm going to take down my slides and pass it off to you, Erika.
Great, thank you. Perfect. Thank you so much for that. And I'm excited to be here sharing some of our work with you all today and look forward to any questions or conversation discussion that we can have at the end. Let me go to the next slide, Christina. Thank you. So since 2017 now, the North Carolina Department of Health and Human Services has been thinking about how we can use our resources across our whole department to really optimize buying health and not just health care. And this has led our department to really incorporate a whole person care focus into all parts of our priorities, including building a statewide infrastructure and implementing incentives to address non-medical drivers of health, focusing on, as Marie, you mentioned, housing, food, transportation, employment, and interpersonal safety and toxic stress. And we know as healthcare payers and providers look for opportunities to better align our healthcare costs and outcomes, a growing body of research is prompting many to really look at what we're calling social determinants of health, or in North Carolina, we're calling healthy opportunities, and to really look beyond the four walls of a hospital or clinic into all the things that drive a person's health. And while we know that there is clear evidence that having an unmet resource needs such as food insecurity or housing insecurity, lack of access to transportation, or experiencing toxic stress or interpersonal violence, there is a lack of this evidence or how to address these unmet resource needs really at scale as part of our healthcare and human services programs. So what we, through our Healthy Opportunity Strategy that I'm going to share a little bit more about with you today, which is for all populations, not just our Medicaid population, although we're doing things specific to Medicaid as well. We really aim to identify and test at scale the changes that are needed to really address non-medical needs or non-medical drivers of health as part of a routine healthcare delivery. So if you go to the next slide, this is our whole healthy opportunities portfolio or our strategy. I'm going to be speaking about a couple of these things today, but just briefly to give you the whole range of the things that we're thinking about. We created a hotspot, a GIS map that goes at the census tract level and shows different disparities of unmet resource needs in our state. So areas where there are food deserts or high concentrations of poverty or other needs at a kind of community level. Then we also really wanted to understand and address these unmet resource needs at the person level. So that is what our screening is getting into. I'll speak more about how we're thinking about screening and implementing screening as well. And then we don't just want to screen for unmet resource needs, but really connect people to the resources in their communities that they need to be healthy and well, which is what NC Care 360 aims to do, and break down those silos between healthcare and human services to be able to send referrals and track outcomes of people's connections to the community resources that they need. We are also doing a lot of work in the workforce space. In addition to kind of a technology solution for connecting folks to resources we know, and I'm sure many of you are aware and working with community health workers or others to trusted folks in communities to connect people to the resources that they need. We're doing a lot of work in better connecting folks to resources like SNAP or WIC or other kind of those types of benefit programs that we know drive health. And then those are for really all populations, but in North Carolina, we are going through a Medicaid transformation right now from a largely fee-for-service Medicaid environment to a managed care environment that we actually just launched a few weeks ago. So we have the opportunity through our 1115 waiver and this transition to Medicaid to embed a focus on these non-medical drivers of health and this healthy opportunity strategy into every single part of our Medicaid program and our waiver. And one very exciting aspect of that is our healthy opportunity pilots, which I'll touch on. So today I'll go more deeply into the screening and Care 360 and the pilots, but wanted to put it in context of all of these different parts of our strategy that aims to address both the systems transformation as well as the financing that we think is needed to really scale these important initiatives. Go to the next slide. Great, thank you. So when our department started this work back in 2017, there were definitely providers or clinics that were already screening for unmet resource needs as part of their workflows, but it wasn't, but not the vast majority. And many of our providers were really asking and thinking about what of the screening tools that are available they should be using, and asking about us those questions. So to address this in, I guess, 2018, the years are a little bit running together, our department worked with a technical advisory group of medical and social care experts in our community to develop a screening tool for North Carolina. And this tool really consists of 9 simple yes or no questions. These questions map to 4 of our 5 priority domains of food and housing, transportation, and interpersonal safety, and really pull from or align from existing tools. So I know many of you will be able to, if you have really good eyes and can see the screening questions on the side of the screen, I'm sure many of these questions look, some of them look familiar to similar to or are aligned with or pulled from things like the hunger vital sign or prepare, the AHC screening that we know that many of our communities were using. And we created this tool because it just as simple as possible to really better fit into workflows, but we also wanted the standardization and screening really allows for us to collect this data in a uniform way to both drive policy decisions and actions at the local level, as well as at the state level. We are excited about this. We have rolled it out across the state. Many of our different healthcare providers have implemented this as part of our Medicaid transformation. Our prepaid health plans are required to use this as part of their care needs screening within 90 days of someone entering their plan, and then periodically thereafter. And we've also worked with partners like Frisia that folks might be aware of, to embed our screening questions into some of those tools, to make it easier for providers to embed it into their workflows, as well as embedding it into NC Care 360. If you go to the next slide. Great. So NC Care 360 screening is critical to identifying these unmet resource needs and is one important step, but we know that screening alone can have a limited impact in isolation, mostly because, especially in healthcare settings, our providers are often don't want to ask the question if there's nothing that in follow-up they can do to refer folks or connect folks to resources in their communities. And NC Care 360 is really trying to address that. And it is the first statewide network that really unites healthcare and human services with the shared technology platform that enables a coordinated and community-oriented person-centered approach for delivering care. So it helps electronically connect those identified with needs to community resources and allows for that feedback and follow-up. We're doing this as part of a public-private partnership, with the Foundation for Health Leadership and Innovation. And then we're partnered with a few different vendor partners that you can see at the bottom are North Carolina 211, the United Way of North Carolina, Unite Us, which is the platform that NC Care 360 is built off of that folks might be familiar with. I know there are some implementations in California as well, and Expound. Oh, I'm trying to move my own slide. So quickly forgot. Could you next slide, please? So NC Care 360 has three main components. We have a resource directory based off of the 211 directory of all the statewide resources we have in the state, with a whole team that goes through those at least annually, some that change more often every 6 months, to really keep those resources up to date, the hours up to date, what services those organizations provide. And all of those resources are put into the NC Care 360 platform. And we are also bringing on all those organizations onto the platform to be able to make these closed loop referrals. Excuse me. So the shared technology platform that NC Care 360 creates, that we're onboarding all of our healthcare providers onto, as well as our community-based organizations, social service agencies, MCOs, et cetera, really enable all these providers to send and receive electronic referrals, seamlessly communicate in real time, securely share client information, and track these outcomes together. And really importantly, and a huge lesson learned that we had in doing this, is that technology is just technology unless people are really trained and empowered to use it. So something that we had planned from the start but have grown in a huge way over the past couple of years of implementation is our community engagement team and network health team, the folks on the ground in our state that are working with our different community-based organizations or health systems or other partners on implementing and fitting NC Care 360 into different workflows, and providing that training and real partnership on the ground to make sure that this works and people can use it to meet their needs and their community's needs. So if you go to the next slide, we started implementing NC Care 360. We started with our first 3 counties in the spring of 2019 and have been rolling out statewide to all 100 North Carolina counties. And we're fully statewide as of June 2020. We changed our strategy to get this out as quickly as possible, expediting our rollout so that we could get this out as quickly as possible during COVID, because we use this as a really critical tool of our COVID response and recovery work, connecting folks to resources that we could actually provide to help people isolate and quarantine and things like that. So we expedited our rollout and are now fully statewide as of June 2020. So far, we have over 2,400 community-based organizations that have among them 4,300 programs on the network, and are growing that month over month to get more of those organizations on the platform. We have most of our health systems in the state on NC Care 360 so far. These are just an example of them. And then as of managed care launch just a few weeks ago, all of our Medicaid prepaid health plans and LMMCOs, which is our behavioral health managed care organizations, are on NC Care 360 and are required to use it as part of their Medicaid contracts. So they're the only folks who are required to use it, but we are using NC Care 360 for all North Carolinians, regardless of payer. So it's not just for Medicaid. And so far we have served over 66,000 people with over almost 176,000 referrals or cases or needs met within NC Care 360. And of those, so far, 74% of those service episodes have been resolved, versus obviously unresolved, but has a specific definition within NC Care 360 that their needs were met or unable to be met because of loss of contact or something else. So we are seeing great success, but we are working on expanding those networks all the time. And another big lesson learned with NC Care 360 is that this is a platform that we are working to break down silos, not just between healthcare and human services, but all of those different types of human service organizations. So all your homeless service providers and other housing resources, your food pantries that have different workflows and food banks, transportation providers, which are often, all of them are often underfunded and sometimes anxious about receiving even more referrals than they were before. So there's definitely been a lot of learning on the different workflows of all those different types of organizations, the ability to have organizations turn off referrals when they reach capacity, how they can really use their data to show their health systems or other philanthropy funders in the community or the state as part of their grant applications to really show the value they're adding to the community to get additional resources to meet those needs that they're receiving more referrals of through NC Care 360. So definitely a lot of lessons learned on how we need to make NC Care 360 meet the needs of these different spaces. It's not just a healthcare context and integration with an EHR. We really need to think about how it integrates with the homeless management information system and other things, which has been a lot of lessons learned and continue to learn as we roll this out. If you go to the next slide, as I mentioned before, all of our Healthy Opportunities work is for all populations. It is not just Medicaid. However, we are using our Medicaid transformation as a huge opportunity to embed all of these different strategies around healthy opportunities into all parts of our Medicaid program. So this kind of visual talks about some of the areas and ways that we're doing this through value-added services and in lieu of services, through our quality strategy and our quality metrics. Our care managers are required to be screening and connecting folks to resources using NC Care 360. Our value-based payment strategy. Through our MLR, we're incentivizing contributions to health-related resources and really counting that as part of health versus admin, and giving incentives as part of plan auto assignment for folks who make plans that make investments in the community-based organizations to really build capacity around healthy opportunities. So those are just a few of the ways. But in my biased opinion, the most exciting part of our Medicaid managed care waiver and transformation is our Healthy Opportunities pilots, which I'll speak to. If you go to the next slide. And forgive me, I'm going to take a drink because apparently in COVID I have not been speaking very much, so I can't handle it. 1 second. Great. So as part of our waiver, CMS authorized our state to spend up to $650 million in state and federal Medicaid dollars to test a series of evidence-based non-medical interventions that are designed to improve health outcomes and reduce healthcare costs of a subset of Medicaid enrollees. And these are across our 4 priority domains of housing, food, transportation, and interpersonal safety. We developed and got approved a series of services for this and created a fee schedule. And this pilot really allows us to pay for, using Medicaid dollars, the things that we all know drive health. So we can actually pay for first month's rent and security deposit and housing case management services, or a medically tailored food box, or home delivered meals, or transportation. And on a later slide, I'll have a better list of all of the subsets still of the services that we can provide, but we have 29 services across those 4 domains. And we will be piloting this in 3 regions of our state. If you go to the next slide. Great. So the real key of all of this is to really evaluate the effectiveness of these select evidence-based non-medical interventions for reducing the healthcare costs and improving the outcomes of our high-risk Medicaid managed care members. And all of this work really is about the evaluation, because we are trying to, at scale, show that these interventions do not only improve someone's food insecurity, but how that improves their health, and then improves their health, decreases their overall healthcare costs. And we want to leverage these evaluation findings at scale, again, to hopefully really embed these effective interventions into our Medicaid program statewide after our waiver is over and this 5-year pilot is over, as part of our sustainable Medicaid program, so that we can support the sustainability of delivering these non-medical services as part of our Medicaid program ongoing. So if you go to the next slide, these are a little bit deeper of a list of the type of services that we can provide. Again, it's 29 services, and we have a whole fee schedule associated that was approved by CMS. But this gives you a little bit of a better sense of the types of services that we can provide. I'm happy to send the link out for our service definitions and our associated fee schedule. One thing I will note is that we held a lot of focus groups with different organizations who provide these types of services, and wanted to not repeat kind of the lessons learned of a fee for service environment in healthcare, and really move towards more kind of value-based payment whenever we could, or at least PMs or something else. And we got a lot of feedback that in some cases that is really valuable and allows that flexibility. And in some cases, we didn't think that that particular provider would be prepared for that. So you'll see when you look at our fee schedule, if you do take a look at that, some of our services are a PM, and some of them are really 15-minute increments for the food nutrition services, or some are up to a cap, for example. So we were trying to push the limit and try not to be fully fee for service, but you'll see elements of that as part of our fee schedule. And if you go to the next slide. Sorry, I think my screen is having a little bit of a delay. There it goes. So this is kind of an example of how we anticipate our pilots will work. 1 second. Forgive me, excuse me. So the key of the pilot is that to the greatest extent possible, we wanted to build the delivery of these non-medical services right into the heart of how we deliver Medicaid services, traditional healthcare services already in our Medicaid program. So upon our evaluation, we can really embed these services directly into our Medicaid program. So what is new is that we're creating what this purple box is showing are network leads. They're kind of a new organization, kind of a hub and spokes model, where they will create a network of human service providers, or CBOs, that can deliver these approved pilot services to eligible members and be paid for those services according to our pilot fee schedule. So that purple box is really creating a network of CBOs who are able to deliver these services to eligible pilot members and receive payment for that. And because this is like an incredibly busy slide, I think an example might make it a little bit more apparent about how we're thinking about things. So if you think about a young child who has asthma, or maybe another qualifying medical, physical, or mental health condition, and their care manager assesses her for pilot eligibility and determines that the child is housing insecure, and that she's been couch surfing with her parents. The care manager determines that the child and her family would need housing assistance, in particular the security deposit, first month's rent, and the housing case management service, so that they can move into their own unit sustainably and stabilize. The care manager would, through NC Care 360, which is also the infrastructure for our pilot as well, the care manager would receive authorization for those services from that child's Medicaid plan, and then they would, upon receiving authorization, would make the referral through NC Care 360 to one of the human service organizations in the network, who like a housing service provider that is in the network of the network lead in that region. And that housing service provider would then work with that child and her family on finding an affordable unit and moving them in, paying for the first month's rent and security deposit, and also providing those sustainability services, connecting them to ongoing financial assistance to pay for rent, or employment services, or other services that they might need to really stabilize in their housing. And that housing provider would also, through NC Care 360, invoice the PHP for those costs, for the PMPM, for the housing case management services, as well as the first month's rent and security deposit up to a cap per the fee schedule that I was talking about. And then they would receive payment directly from that child's Medicaid plan. So that is how we are envisioning it. It is baked into our Medicaid program to the greatest extent possible, with this incorporation of a network of human service organizations as well. Go to our next slide. I don't know if this will be incredibly relevant to you all, as I'm sure you're not incredibly familiar with North Carolina counties, but we are operating this in 3 different regions in our state that were competitively procured. And we just selected these regions, I guess, a few months ago at this point in May. So we are launching that now. So I will stop there and see if folks have any questions or any more detail that I can provide. Thank you.
Thank you so much, Erika. I'll give you a chance to catch your breath and grab a sip of water if you need it.
Geez, I have a frog in my throat or something. I don't know what's going on, but sorry about that.
No, it's not a problem. We're all human. Thank you so much for sharing the first part of your presentation with us. So I invite the group, if you have any questions, just put your name in the chat box and we'll invite you to open your line and ask Erika a question if you have it. So just put your name in the chat. We'll keep a running list. In the meantime, Erika, I have a few questions for you, so I'll kick us off. It's interesting what you said about, the work is really more about, it's not just how do we integrate this into the EHRs and the EMRs, but it's about how are you going to integrate this into all of the CBOs that you're working with and all of their platforms to really make sure, that there's seamless transition and referrals for these patients and community members. And to that end, one of the things that we talk about a lot in the network is around building kind of deep partnerships between the healthcare field and community-based organizations. So I'm wondering if you can just share a little bit about what you've seen and heard from this work around what it takes to kind of build partnerships between healthcare organizations and community-based organizations.
Sure. So I could answer this question in 100 different ways and 100 different learnings that we've had, and also acknowledging that this is definitely still a work in progress in all different parts of our strategy. But I think there is both a sense to not over medicalize our response and our working with CBOs who do not live or work in that environment for a reason. That is not how their services are traditionally delivered. But we also want to build capacity and in our community that will really come by these true partnerships and ability to potentially, in some cases, contract with or partner with in other ways, either their health systems or their health plans. So finding that balance is something that I think we are definitely still working on. And I think even as part of our implementation for our healthy opportunity pilots, finding that right balance of not fully over medicalizing the way these services are delivered, but making sure there's the same level of accountability and stewardship of our funds and resources and data for our evaluation that is needed for a Medicaid program. So definitely finding that balance. I think that NC Care 360 has been really helpful in providing visibility on both sides of healthcare and more community-based organizations as well, of their different capacity constraints or lack of kind of understanding, especially when we first launched NC Care 360, we saw a ton of referrals that were rejected, which is really disheartening to everyone when they first onboard and onto a new community platform. But there was one in particular where they kept sending one, and the folks that they were sending weren't eligible for that service. And before NC Care 360, they had continued to send people to that organization. It was a transportation provider in this particular example that I'm thinking of, but had happened a number of different places. So they had been sending folks to that organization for a transportation resource that 90% of them weren't eligible for. And folks took time out of their day or took off work or figured out how to get to this organization and were told no there. So it really was helped to inform our healthcare providers and other CBOs that were making those referrals on what those eligibility criteria were, which was helpful. We also fixed our platform a little bit to make sure that front and center, those eligibility requirements are there. So just providing more of those awareness around those different constraints in our service delivery system. And then I would say that it also has elicited the lack of capacity and opportunity for growing capacity in these partnerships. Many of our CBOs have used data from NC Care 360 on the value that they're providing to their healthcare partners or others to currently mostly to inform grant applications through philanthropy or community benefit dollars, but hopefully ultimately to think about contracting arrangements or value-added services or value-based contracting or things along those lines in the future. And our pilots we're really looking forward to as an opportunity to really test these new models for financing and growing capacity in our communities through our healthcare dollars, because we know how incredibly connected they are.
Great, thank you. It's really interesting to hear, about that. I wanted to just know, so what's next? What's next for North Carolina Department of Health and Human Services around this work?
Great, so that's also could be a very long-winded question, so I'll try to hit the highlights, but we have been designing our pilots I've been with the department for 4.5 years. So for 4.5 years plus, we've been designing our pilots and are just getting to implementation. We just selected our pilot regions and are rolling those out and actually hope to be delivering services next year. So that'll be really exciting to see it in action. Our NC Care 360 work, we are fully statewide, as I mentioned, but are continuously growing that network and making it a more powerful resource as we grow in communities and thinking about all the different integrations and opportunities that we have. It was, again, as I mentioned, a really powerful infrastructure to build on and part of our COVID response and recovery to have all of our different players on the same platform to make those community referrals to especially new CARES Act or art funding in the future activities that were available for folks, which was really helpful. And I think also what we are, now that we are either have implemented or executed or are almost there, we are getting a ton of data from all of this and are pulling in all of that data and have a accompanying kind of data strategy of how we can better connect people to resources and also see how that is impacting healthcare costs so that we can figure out how to better scale all of this work. So those are just some of the pieces of how we're kind of improving or just at the precipice of implementation or launch, or improving those things that are launched, and the key of all the data behind it and how we can use that to better inform policy, but also make direct outreach to different folks that can benefit from some of the services we provide, whether it be SNAP or WIC or Medicaid services, et cetera.
Great, thank you so much, Erika. We do have some questions in the queue, and reminder for anyone else, if you have a question, just put your name in the chat box and we'll add you to the list. So I know I'm not going to pronounce this correctly, but I'll try. Masood, if you can feel free to open your line and introduce yourself, and you can ask your question, Erika.
Okay, great, thank you. My name is Masood Agahi. I'm in Los Angeles. I'm involved in a training program for community health workers, and I'm curious how CHWs factor in your programs and your pilots, and what specifically have you carved out roles for community health workers to play, if any, and how you could see their role expanding as you go forward, in what capacity?
Sure. So over the past few years, our larger team at the department has been doing a ton of work in partnership with other community partners and our community colleges and college systems on our community health worker work. Some of that was creating a curriculum a standardized curriculum that we launched at a number of our different community colleges and other places to have a training process for community health workers, an accreditation process and things, or credentialing process and things like that after for community health workers. So that was all work kind of going on in different pilot phases ahead of COVID, and COVID really gave us an opportunity to expedite all the work going on around community health workers and really show that proof of concept further and the need. So we am happy to share more information around this because I didn't touch on it much, but we were able to procure a number of different organizations that covered through a community health worker workforce of over 400 at first. I think it grew to maybe 500 or 600. I'm blanking on the numbers from just a few months ago, but workforce across the state to connect folks who were screened as exposed or had COVID to community resources. They used NC Care 360 to connect to community resources and other networks for more medical services. So that was hugely effective, and they served thousands and thousands of people in that program, funded through CARES Act funding. And we're also, through our support services program, actually able to, because our pilots were a bit on hold because of COVID, use that same framework to connect people to the same types of services at a smaller scale, using some CARES Act funding and using our community health workers as kind of the care managers in the workflow that I had showed in that slide, that really kind of busy flow chart. So that was a huge proof of concept ahead of managed care launch and ahead of our Healthy Opportunities pilots, the use and need for community health workers to be that essential connector to resources, and show how that improves health. And we have done some evaluation on the impact that community health workers have had on COVID spread and COVID outcomes as a result of some of that work, which is really powerful and interesting. And now in 2021, because that was all in 2020, we are once again procuring to even have this now statewide, the same community health worker work, both for our COVID response and recovery, but now also hopefully for sustainability through our Medicaid health plans to be hiring these same community health workers as part of their workforce. So that's all a work in progress, but excited to be expanding, at least in the near term, what we had piloted during COVID.
So the exemption for Medicaid does cover reimbursement for community health worker services directly?
So on the department side, it's all because it's a managed care environment, but we're working with all of our plans to be including community health workers as part of their care teams.
Thank you.
A similar question from another attendee, Caroline, just wanted to know what the role of oral health providers are in the program, where they fit, what their role is.
I'm sorry, what providers?
Oral health.
Oh, so as it pertains to, I guess all of this work or oral health for the most part is could be a part and is a part in many parts of our state of much of this work. So screening is happening in some of those places. We are onboarding some of our oral health providers or those that provide oral health care at no cost, some of our oral health collaborative work that are actually Foundation for Health Leadership and Innovation in our Rural Health Center, who's our private partner on our NC Care 360 lead and in partnership with many in North Carolina. So some of those partners that provide that care are on NC Care 360. And then for our Healthy Opportunities pilots, the initial front door could be anywhere. So we would anticipate that we would be definitely educating about this to our oral health providers, in addition to our other physical or mental health providers, pharmacists and others that are using NC Care 360 and could be making referrals into the pilots to be assessed by care managers and connected to those services. So they could be a component of all different parts of our strategy. So thank you, Caroline.
Great, thank you so much, Erika. Any other questions from the group? All right, well, I will happily give everyone back 15 minutes their day. I know we're all busy people. So Erika, thank you so much for taking the time to share your work with us today. It's so wonderful to hear what other states are doing. For all of you on the call, we will be sharing, this recording will be posted on our website as we typically do. My colleague Christina is going to launch a poll here. If you could please take it, that'll help us better understand how we can get you more and better content. So thanks everyone. Thank you, Erika. Really appreciate you taking the time.
Awesome. Thanks so much. We've learned a lot from North Carolina or from California. So happy to share. Thanks all.